So it looked like there was a lot of great discussion during the breakout session, and we are looking forward to reading all of your thoughts that didn't get actually commented on live, but the ones we did hear were really great and important needs and gaps to identify. So thank you for that. I would like to introduce our next panel, Translating Insights into Action. And I am going to just introduce our moderator, Dr. Julia Campbell, clinical professor at University of Texas at Austin. And Julia is going to take it away.
Hi, everybody. Welcome back. So I am an audiologist and an auditory neuroscientist on the side. So I have a bit of a oddball background. But we're kind of starting to wind down the day and the conference, and we have heard several different types of approaches, maybe some mechanisms that we're finding to be important in misophonia. But how can we translate that now in real time to help people who are suffering? How do we not keep this lost in research land or PubMed forever? So what we're going to talk about right now is what we know and how can we use what we know now to help now. Okay. So I'm going to let everyone introduce themselves and give a little blurb on their background, and then we'll kind of get into it.
Hello. This is on, yeah. So my name is Fatima Hussain. I am a cognitive computational neuroscientist by training, but I've always studied hearing and hearing disorders. So for the past 20 years, I've studied tinnitus, which is a perception of involuntary self-generated sounds. So these are sounds that don't exist in the real world, but you hear them. So I have been studying that, and more recently hyperacusis, which, as we know, is sensitivity, in this case, to loudness of sounds, everyday sounds. And about 6-7 years ago, I was invited to be part of a workshop here on misophonia, hosted by the Miller family and the Ream Foundation, which was a brief day and a half of workshop where we discussed all things misophonia related. And that's when I began my study of misophonia, to tell you the truth. It was not on my radar prior to that. And I can see how the great strides in research that have occurred in misophonia, in understanding misophonia and treating misophonia, thanks to that one tiny workshop and how it grew. So that's my story.
Hi, everyone. My name is Andrew Guzik. I'm a clinical psychologist, and my introduction to misophonia was probably 11 or 12 years ago. I was working in an OCD clinic, and I came across a teenager who was in our program who also had misophonia. And it was a really important, compelling case where a lot of really dramatic change was made, and this teen ended up on the other side in a much different place, and it was very inspiring. Years later, I was really fortunate to have a postdoc award from the Misophonia Research Fund, where I got to dive into this in a lot more detail. And I immediately started learning about how this one case that I had all these years ago was not necessarily representative of the infinite complexity of misophonia, and how much more there was to learn. I spent several years doing research focused on kids with misophonia, especially trying to understand the psychological presentation. And we would do these studies. I'd get to know families, and every time the question was, so what do we do about this? Where's the treatment? Where should I go to get help? And so a few months ago, I opened a private practice where I'm focused largely on doing CBT, which we heard about a little bit earlier, for kids and adults with misophonia, with OCD in particular. And I'm continuing to keep up with some of my research as well, but I've shifted from before. I was really focused on trying to understand misophonia, especially in kids, and doing a little bit of therapy as well, to now mostly focusing on therapy and also continuing to participate a little bit and trying to advance our understanding.
Cool. Hi, everyone. I'm Adil Ahmad, host of the Misophonia podcast, which has been going on almost 6 years now. almost 250,000 downloads. I'm also a software engineer and entrepreneur. Most recently, I founded basically a personalized AI health assistant. And then combining misophonia and software, I've also, to kind of scratch my own itch, built a research grade computation platform that mines insights from lived experience data, starting with podcast transcripts, but this could apply to a lot of different input modalities. So yeah, there will be a white paper published, I think maybe later today, if anyone wants to poke holes into it. But yeah, I'm glad to be here, and I'll pass it on to Tiffany for now.
I'm Tiffany Wojnarowski. I'm a professor at Vanderbilt University Medical Center and also an adjunct professor at the University of Hawaii. I study sensory development and its disruptions and disorders like misophonia, with a special interest in individuals with neurodevelopmental conditions across the lifespan. And my work is motivated by my personal experience. First, growing up as the child of a father who had misophonia, as Jeff said earlier, during a time when we didn't know the name for the condition, and then becoming a person with misophonia myself, and now being the parent of a daughter with misophonia and a son who has autism and hyperacusis. So happy to be here.
Thank you all. So one thing I would like to talk about is how each of you would go about including families in the therapy or intervention process for helping someone with misophonia.
I can start on this one. I really see this as a interpersonal problem. So often triggers are produced by other people. It's the most common context. So when the context is so often interpersonal, and when it is so often happening within parents and their kids, then it seems like you have to involve parents. I think one, there's many different directions we can go there, but as a starting point, coming to a shared understanding where we are working together as a team instead of against each other, and that we can treat each other with compassion, and trying to have compassionate conversations between parents and their kids and understand how that can extend to those moment to moment experiences can make a huge difference. We've heard a lot about that today. You think about, misophonia can so often be the thief of compassion for people who are otherwise very kind and generous and loving. That misophonia moment, you might feel real hatred, and then you might feel a lot of hatred towards yourself in the aftermath. Parents might be defensive themselves, and so trying to recognize how this moment is the thief of how we really strive to feel, and where our family values and how we can bring love back into this conversation is, I think, a really important step.
If I could extend on the idea of compassion a little bit, but maybe from a slightly different and contrarian angle, perhaps. I think from my vantage point, at least, from someone who kind of casually excavates the backgrounds of people who have misophonia, I think there needs to be more focus on the pre-onset period and environment of people who have misophonia. I think there's a little bit of a taboo around, and it makes sense. There's a lot of potential for parent blaming, but I think this has become kind of a third rail of misophonia, and it doesn't have to be about parent blaming. It's there's a lot of factors that could happen, but I think we're kind of like shying away a little bit too much. So I think it's opened up a blind spot. I see misophonia as potentially predispositions, and this could be genetic, this could be epigenetic, it could be structural. There's later moderators, which are like coping methods, CBT and whatnot. But I think early moderators, I think there's a giant green space and kind of blind spot that we're not really looking at, and that could be family dynamics, it could be emotional climate, ACEs. So I would like to see that, and I'd like to see that approach with compassion, because I don't think it has to be about blaming anybody.
Well, I'll jump in here if that's okay, because I appreciate that fabulous segue, Adil. One thing that I'm really interested in doing moving forward is developing very early preemptive interventions. This may sound really far afield of where we are right now, as most of our intervention studies over the past 25 years since we coined the term misophonia have been focused more so on adolescents and adults. But we see this happening in other fields like autism, where we've identified the early predictors of the condition, and then we can develop interventions that can be delivered very early in life to prevent at least the consequences of the condition or mitigate them to some degree. And a lot of times, these types of interventions are targeting the family system, teaching caregivers who we are not blaming for the condition. And I'd like to be on the record saying I do not believe that parents cause misophonia, but parents may support children who are developing misophonia, and we can equip them to do that by developing these types of interventions.
Great, thank you. Another question might be, what I saw at our table with discussion is, where do parents or loved ones start? Where do they start to look for help, for support? And how can we put that information out there or guide them in a better, more successful way?
I feel like you may need to take this one to start, Andrew, since you've been talking a lot to parents and children and learning about how much they still need to
Yeah,
find support and identify people who are even aware of what misophonia is.
yes, and the reason I didn't jump in is because unfortunately I don't have a very good answer. I could talk about where it would be wonderful to see us going, but there are efforts happening right now that I'm aware of online, where directories of providers who know about misophonia are being put together on So Quiet. And I know the CMER website has a nice guidelines for families or for people with misophonia, what steps they might take to find someone who is likely to be qualified or helpful or effective. And those types of resources seem like the type of thing that we need to do. Sadly, there are very few professionals, to my knowledge, who own this problem and really spend a lot of time deeply thinking about this problem. Of course, as we heard about, there's lots of people who are very competent in, say, for example, cognitive behavioral therapy or ACT, who might be able to flex those. But I do believe, sort of as it was said before, it's not quite enough to just be really skilled CBT therapists. You do need to have some experience under your belt. You do need to know something about the unique difficulties that this population is facing. And until we have a large group of people across disciplines, audiologists, therapists, et cetera, who can do that, then I like, unfortunately, I don't feel like I have a good answer to the question, which I think is, where do we go? I think, like I said, I know a couple places, but I think those
Yeah.
efforts need to be expanded.
And I think that's just where we are right now. I think
Yeah.
that families are struggling to find support. I like to throw grandiose ideas out there. So I would just say, if we could look into the future, ideally, I would love for families to easily be able to access centers that are on the cutting edge of assessment and treatment, that are working to advance awareness, promote discovery, and train the next generation of clinicians and scientists who will work in this field. And it may sound like a really big idea, but it's not something that we couldn't accomplish together. We have these types of centers that are focused on, excellence in specific conditions, things like autism, or other types of neurodevelopmental or neurogenic conditions. And we could establish a network like this together around the country, or maybe even around the world. 10 years out, with lots of
Yeah.
infrastructure
Yeah.
and lots of
course.
funding.
No, I think that would be great. I think, we have audiologists, because I am one, so I'm biased, that are dealing or seeing these patients. And in Austin, I don't have any psychologists or psychotherapists that I can draw from or send to. So how can we create a holistic or a team-centered approach fast or now to support families and the individual suffering that way, so that we're not going outside of our scope of practice, that we're looking at the auditory pathways and assessing those, but also being able to give, psychotherapy based treatment, which seems to be right now, I think, the best option based on what we've heard from the talks today.
I agree. I think that's where we need to go. I can we go there today? I think I struggle with some of the practicalities of as you said, where you're located, you have trouble knowing who else is specializing. So maybe we can do better creating
Mhm.
networks that extend across your local geography to have some better interdisciplinary dialogues and case consultations. But down the road, I agree. That's the vision is you go to a clinic where you see an audiologist, an occupational therapist, and a therapist, and a psychiatrist, and you got a personalized treatment plan with everybody's expertise. That is ultimately, I think that would be a dream for many people who are struggling.
And that sounds expensive to me, if I can be a little contrarian. I don't know how many insurance companies are going to pay for 10 different specialists. But I agree that I think audiologists can maybe, no offense, just kind of stay in their lane on certain things. And I think it would be great to have somebody, a psychotherapist, who has a bird's eye view on what's happening to the whatever age group that person is in, to kind of see a holistic view.
My last question before we go to the audience is based on your experience and your work, what is something that you would put into action right now in the clinic?
Speaking as a researcher and not a clinician, I would like to see more longitudinal studies. I want to have the same person followed for years to see what changes in the presentation of this condition. So when I talk to participants in our studies, some say, right now I have one trigger sound. When I was younger, I had two trigger sounds, right? So they have managed to, on their own, come up with solutions that work for them about the type of triggers they have. And so can we leverage some of that, right? So I would like to see studies, even with intervention studies that do follow up, because that's not often the case. And I know Jane said about 2 years and things, that how we are seeing changes in some, at least with sound therapy, right? And there is no drawbacks in there to use this kind of intervention. So I would like to see longer follow-ups. I want to see more longitudinal studies. And I want to understand, if I was, let's say, 20 years old and I am experiencing misophonia, what is my prognosis, right? I want to see what happens to my condition when I'm 40 years old. And the same way, thinking in terms of the parents, like, this is the presentation at 12. What happens when they're 22? What happens when they're 42? What happens when you have the sort of this typical ups and downs of life, right? With your hormones, with getting married, with childbirth, and so on. So that is not, I think, very well documented. That's my sense. I may be wrong, but my sense is, how do we use that information then, right? So I think that's for me, a huge gap in my understanding of misophonia is this longitudinal progression.
The dynamics.
And because then we will be able to understand when we perturb or change it with an intervention, what exactly has happened as well, right? So there may be these ups and downs in this presentation, which are sort of very typical or natural. And then what happens as we perturb it with an intervention? Is it within that, or have you really changed the dynamics?
Great.
I'll jump in unless you want to add, Deal.
Yeah, well, I was just gonna say, since we were talking about studies that we might like, I think I'm not aware of any. I know there were some studies to traumatic stress that were focused on hardcore PTSD, but I think I'd like to see other assessments. Well, first of all, longitudinal studies, yes, but I think we can use the ACE, Adverse Childhood environment, FES, family environment scale, CTQ. I think there's a plethora of assessments I think that we should be using in more studies.
One thing that we've learned from research in my lab and others is that misophonia tends to be more prevalent and more pronounced in individuals with neurodevelopmental conditions like autism, yet at the same time, they remain understudied. In fact, having been excluded from a lot of past studies to date. So we really don't know what constitutes evidence-based practice for this particular subgroup that is affected by misophonia and sound tolerance issues. I think we could also question whether the studies that have acquired some empirical support to date are going to be optimal for this population, given that they struggle with things like metacognition and executive function that are inherent in participating in something like cognitive behavioral therapy. I also know that these individuals are very rarely receiving targeted treatment for their sound tolerance issues. Typically in treatment, clinicians are prioritizing other targets, despite the fact that individuals with autism are saying that their sound tolerance problems are amongst the most disabling characteristics that they experience, and they're very persistent as well. So going forward, I would like to see us make some progress along those lines.
Thank you. I would like to put it to the audience. Any questions?
So this is for Dr. Gusick or anybody. So you referred to misophonia as an interpersonal problem. Is it? Or is misophonia a problem, a perceptual problem, a problem of sensory awareness or a perception that causes interpersonal problems? Because if you say, we talk about addiction being a family affair, it's a family disease, but we don't say someone in a wheelchair, it's a family disease or a family problem. And I think if we say misophonia is a this, that causes interpersonal problems, because one of the things that I've noticed throughout the day is that the onus of responsibility keeps coming back to the individual as the locus of origin, the locus of control, the locus of taking care of yourself. And I'm, as a parent, I'm like, what does an ally look like then in that model, where it keeps going back to the individual and we talk about it as an interpersonal problem. If we take the people out of it and make it not an interpersonal problem, but a sensory problem that causes interpersonal issues, is there a better role for allies? So it's kind of a lot in that question, but I guess it's that language that made me wonder, wow, should we be calling it an interpersonal problem?
I think let's see if I can take this. So I'm kind of mentally going on many threads because I hear you. I appreciate the question. I think I think the way that you phrased it is more precise. The way that we're studying misophonia right now, at least, is a complicated problem related to many factors involving the brain and ideological processing and psychological factors. And that ends up expressing itself in relationships, and interpersonal problems might emerge from that. However, and so I think your phrasing is really more precise. And you can imagine a situation where a person, say a child is struggling with misophonia, they try to express what they're feeling, they're having trouble finding the right words. Parents might provide a response that comes from a place of not understanding, of being defensive, of believing their child doesn't have good manners. And now they're shutting down the opportunity for emotional expression. And now there's maybe some emotional suppression. And now maybe there's even more pent up emotional pain in those misophonia moments. And now there's an interpersonal mechanism that could be at play, that could be contributing to this misophonia continuing. And so in that way, there are interpersonal problems that do tie back to the misophonia itself, in a sense. So I hope that answered your question.
Yeah, sure. Yeah.
Yeah.
Thank you.
Okay, there's a quote about changing fields. You need to begin at the nurseries. And I'm curious about the role of shaping education. You talked about centers. What about university clinics? You know, as it is, as somebody who administers a university clinic, we are constantly not making, our ends meet with respect to finances, but we're also not constrained by insurance in ways that other places are. And it's also a potent place for interprofessional training. And it is unfortunately not as high functioning as they should be. And there's a university clinic almost across the entire US at least. So just your thoughts on that.
Okay, maybe I can start. So I think the concept of university clinics should be for the greater good, right? That is something that academia is doing for the community. So I think once we start from that point, then everything becomes, I think, simpler. What I find in practice not working is the clinical psychology program working with the clinical audiology program. That doesn't seem to work as much. And I think partly it's because the training sometimes is so intensive that it becomes very challenging for the students to have these kind of collaborations. I think at the level of the faculty that sometimes happens, but it doesn't translate into individual students being able to do that. So maybe that can be a goal as well, which is that at very early stages in the career, the clinicians are working with another profession. And I think that hasn't occurred, at least in my experience. And I think that's a huge opportunity there. If this is what you're alluding, Bharat, that makes a lot of sense to me.
I think that's an ideal situation because you do have the interdisciplinary resources right there. And you have students who are going to want to be learning that. I don't know why we don't see that more. I don't know. And it's perplexing and confusing for me as well.
And maybe misophonia is a good condition in all senses of the word to begin that, right? So there are conditions like hearing loss, for instance, that can be wholly treated within the discipline of audiology. And there may be other conditions that may be wholly treated within the discipline of clinical psychology or whatever. But I know we've been talking about this all day about misophonia being this condition which is sort of cross-cutting in terms of its presentation and in terms of its treatment. And so maybe in that sense, this is a good starting point, a good seeding opportunity to have the diverse clinical disciplines come together because you need that. And then going back to the idea of having OT, for instance, helping, and that seems to be the occupational therapy seems to be working a lot with families, and that we can bring that in as well. So maybe we need a condition to start that rather than top down saying, okay, let's just meet together for like so many meetings, not over lunch, and then continue to talk and talk and talk, right? Which goes nowhere. But if there is an imperative need, like we have these patients, we have these families, we really need to help them, and then use that to train the students, I think it'll work faster and better.
And I also think maybe it hasn't been the right time yet for that interdisciplinary work to occur because we just didn't have the knowledge of what works or seems to work, what mechanisms might be at play. And I think now we're at a good enough point that we can begin to do that, especially at university clinics.
And we definitely see this happening in university clinics that are specialized in other conditions, right? where we have interdisciplinary practice that's really on the cutting edge. We're all working together to develop and test novel interventions and roll them out, ensure that they're accessible to all of the patients who we serve. It's really an ideal training ground, I think, for the next generation of clinicians and scientists who would like to specialize in misophonia. There just isn't any university clinic, to my knowledge, at this point who's doing it, right? But possibly we could pursue something like training grants or something to work on this together.
Should we switch to Zoom audience or? Go ahead.
Hi. Hi, Julia. Can you hear me?
Yes, loud and clear.
Okay, great. One question here. What is the correlation between autism and misophonia? What have you found? When there is sound sensitivity, how do you distinguish that from the kinds of sound sensitivity in ASD?
Take this one. Okay, I'll take this one because this is my area of expertise. We have done studies specifically looking at characterizing sound tolerance and determining the prevalence of different sound tolerance conditions in autism, specifically in autistic adults. We found very high co-occurrence between autism and misophonia, with nearly a third of autistic adults meeting caseness criteria for misophonia, and even more meeting case criteria for hyperacusis, with many adults having both conditions. So that's the nature of the correlation. It's quite high, the co-occurrence between conditions.
I'll just add to that another question. How are we differentiating between hyperacusis, misophonia, and other disorders such as auditory processing disorder, in addition to just generalized over-responsivity to having a lot of sound in the environment? Or should we be doing that in the research?
Maybe I can begin, and Julia and Tiffany can jump in. So we can, a lot of it, and I know it going back to Dr. Jamie Ward's talk this morning, the gold standard remains a structured clinical interview in clinical psychology, right? And some of that has now been adopted by audiology in the sense that the differential diagnosis happens at the level of this interview. There are instruments that help us. So we have questionnaires on misophonia. We have questionnaires on hyperacusis and how they present. We also have loudness discomfort levels that we can do to test the response of the individual to different loudness of sounds. We have tests we can do in terms of the auditory processing disorders. So you can imagine if there is a child of, let's say, 10 or 12 coming in, and you're doing all these different instruments, and then the clinician is looking at them and putting things together as they're talking with the child and the family. That makes sense. So there is some of that, but it seems to me the best practices right now that are happening end with this kind of consultation with the audiologist or the clinical psychologist, if that makes sense.
It's very complicated, of course, as everything is. So there's a big debate and controversy within the audiologic field as to whether misophonia is a type of hyperacusis, a subtype, or an independent disorder. So it depends on who you ask or who you talk to as to the answer you'll get for that question. In my opinion, you can have hyperacusis and misophonia co-occur, like Tiffany just said, and that is very common. But they can be separate as well or independent. So what I do clinically is I test for hyperacusis because we have a few audiologic steps that we can take to see if it's present. I look at these loudness discomfort levels, but I also use a questionnaire. I have to have agreement between the questionnaire and the loudness discomfort levels to provide a diagnosis of hyperacusis. If one is positive, I don't see that as being positive for hyperacusis. So I have to see it in several dimensions. Misophonia, we use questionnaires because that's what we have. So again, it is possible to have both. Auditory processing disorder is a very different beast. That has to do with speech perception and noise specifically, and having issues even though you might have normal or near normal hearing. So that really isn't an intolerance problem, but more of a distinct processing problem. So that's the difference between that. But again, hyperacusis and misophonia, we don't really know the difference, if there should be a differential diagnosis or not. That's something we need to answer, and it's very important.
Let me use my microphone voice. I'll add to that just a little bit because you asked how you might disentangle this from generalized sensory differences. And I do think that it is also important to characterize the broader sensory profile of individuals who are experiencing difficulty with trigger sounds and are reporting difficulty with loudness perception, possibly have misophonia and or hyperacusis, because we've seen that many of these individuals also have generalized what we would call like sensory sensitivity. It can also be called hyper-responsiveness, hyper-reactivity, and there are previously developed and validated measures of that generalized tendency to overreact to sensory stimuli across modalities. People like OTs, we've got one over here, Tammy, are really great at characterizing broader sensory profiles like that and have the tools to do so and may be able to provide supports when there are these kind of broader issues at play.
Are there any more online,
Yes,
Jennifer?
a couple more questions. Maybe we only have time for one, but how many people do you think are at the highest end of the misophonia scales? People who are not able to live any sort of typical life.
I can start to try to answer this question. There's been, we don't know definitively the answer to that question. If we want to say the gold standard for understanding if someone has misophonia is a validated interview, then what we would need to do is like the Duke misophonia interview, for example, we would need to develop a screening question. We would need to get a bunch of people together. Some of them have misophonia confirmed by this gold standard interview. Some of them don't. And then we would give all those people the same very brief validated misophonia screening questionnaire. And we can get a number that says this really does a good job of guessing who had misophonia based on the interview and who didn't. And then we gave that to thousands of people who represent the general population. And then we can see how many people scored over that number. And that like specific step-by-step process of figuring it out hasn't happened yet. And so you see different numbers floating around. And I think until we have that very clear step-by-step guidance, it would be difficult for any of us to answer that question with any real confidence.
I want to say something random because I see the clock running down before we have the next question. I just kind of want to throw this out there. But I was reading about the cliff edge model in schizophrenia, and that kind of resonated with me. The cliff edge model is basically the idea that a super maladaptive trait does not leave the gene pool because there is a lesser extreme version that happens to be was decided by evolution that it's okay to have a few people who go over the edge with something like schizophrenia. If the less extreme versions, in this case creativity and other positive things, are moving the species forward, like I would like to see that looked at for misophonia because I don't have to explain, you can imagine how there are parts of misophonia that are positive for the species. And couple that with the idea of the diathesis stress model, which is simply moderators, like I talked about before, that could activate or amplify genetic predispositions. So I think the two of those, some people call it the ideal model of misophonia, but I would like to see that looked at.
just follow up on that. So my period, I was just telling over there, was because I study tinnitus, I have believed for a while now that all of us have tinnitus at some point, right? We have very periodic one. When we go to a loud concert, it just is subthreshold a lot of the times. It just becomes for a few chronic and continuous, right? So the same way we can imagine misophonia exists on a spectrum, as we know, and for a lot of us, these sounds are subacute, let's say, subthreshold, and so I do buy into that. And so if I understand the question correctly, they were asking what was the most extreme parts, or the most severe bothersome misophonia, how would that look and present? And I don't know if I misunderstood the question. So for me, that would be where it is constant, it's chronic, and it presents with a lot of other comorbidities, right? Very significant comorbidities that affect your activities of daily living, your ability to go to school, your ability to work, your ability to function in the family, and so on. So, and then there would be those of us who just get irritated with people chewing with the mouths open, but then we get over it, and it doesn't present to the extent it would present for individuals who can be correctly identified as having misophonia, if that makes sense. That to me, this is the spectrum of human experience with sounds, if that makes sense, with a lot of these sounds. But that's just my personal opinion.
Thank you, everybody. Oh, wait.
Wait. I have a question for the other panelists.
She's gone rogue.
So my question is, what is it that you did not see in our discussion today? I know we discussed many, many things about misophonia. What is it that you did not see? What was the one absence of one aspect of misophonia, research or lived experience or clinical aspect that you did not see or hear being discussed today? That's my question.
For me, I mean, it's clearly the pre-onset environment.
Okay.
I saw a lot of everything is pretty much post-onset, or anything pre is kind of like framed as a neurodevelopmental. So, and anything kind of like that approached pre-onset was often swatted down. So I'd like to see a little bit more depth around that.
I loved Dr. Ward's picture with the tree. Yeah, thinking about, I found that very compelling, thinking about what's going on that's watering that little seed that's growing it into this tree, kind of to some of the early intervention conversation happening before. That feels like a very important question. I agree.
I'll just say that I actually am thinking about what happens prior to the onset of misophonia or prior to misophonia becoming fully consolidated. And my team is currently trying to study that. Just what are the biobehavioral predictors of misophonia beginning as early as infancy? So hopefully you will hear that sometime in the conversation in the future. But if I could comment on just something that I haven't heard that I've been thinking a lot about, it's the fact that misophonia is affecting people from all different demographic groups all around the world.
Mhm.
And if you look at the samples that have been included in our research studies up to this point, they comprise largely adults and are very homogenous. And I would like to see us be more intentional about advancing our science in that way to ensure we are including representative samples and that the findings from our research studies will thus generalize to all of the people who are suffering from misophonia.
What about me? I would like to see a study or multiple studies look at the development of the central auditory system in conjunction with the visual system from young, I don't know, 3 on. We know that there's major changes in both those systems across age, and what might differ in that developmental course physiologically that would lend to the symptoms of misophonia.
Maybe I can answer my own question too. So it actually mirrors some of these trends. So, so when I first learned about stuttering. So I don't know if you know that stuttering is very common in young children, but a lot of children who stutter recover from it. There is a spontaneous remission from stuttering. There are only like 5% of the individuals who start stuttering go on to persist with stuttering as adults. So that has always stayed with me. So I'm wondering if there is some similar trajectory with misophonia, right? We do get through acute episodes of different things. So I study this in tinnitus. We have acute episodes of tinnitus. We have intermittent tinnitus, and only certain population does it persist and become chronic. So thinking about all those disorders makes me think whether there is that um, uh, association or with misophonia as well. And then which would also want me at some point, if it has ever been documented, about spontaneous remission from misophonia in young children, right? As I said, I talk to people, just in, and one of the students at my university, actually a postdoc fellow at my university, said she had it between the ages of 14 till about 20, and it was to her father's sounds of chewing. And she recovered from it at the age of around 20 when she went off to college and got that separation from her father. So that was how she talked to me about her misophonia. And I don't see that, but I'm wondering about that, as Adil was saying, what are those markers? But I feel that there is some story we're missing on this end and some story we're missing over there as well.
That was a great question. Thank you, Fatima. We have one more question from the audience, and then we're going to move on.
Thank you. First of all, I'd like to thank everyone in this room that does the work that you do. It's very important work. And I have a very simple question. I'm here representing my daughter, who has a daughter, my granddaughter, who has misophonia. As she takes or searches for someone, a clinician, to work with her, what do you recommend that we search for, and what we ask that clinician to do, given the infancy of everything I've heard today? What should we be asking to make sure that we're pairing my granddaughter with someone that's going to provide her with the assistance that she needs right now? What are the important things we should identify?
Sure, I can start. I can try to take this question from a therapy psychology perspective. As you heard earlier, what we believe at this time to be the most effective therapies for kids with misophonia follows the cognitive behavioral or ACT models. So finding a therapist who's really has strong competence in CBT or ACT would be important. And I would also ask if they're familiar with misophonia at a minimum, and if they have experience with misophonia, because what I would hate to happen to your granddaughter and your daughters, for them to have the experience that we've heard about again and again, going to a provider who, yeah, I know CBT. No, wait, explain what this is you're struggling with. Now they're catching up with your daughter and your granddaughter as they're trying to explain it to them. And now they're feeling not heard and not understood. So it is true that these cognitive behavioral principles that we're applying to misophonia are tried and true. And it is also true that it's not as simple as finding a good CBT therapist. I do believe some real experience in misophonia at a minimum. You're probably not going to find someone with a wealth of experience, but some, grasp of this problem, they're not teaching it to them, would be important too.
Comment here because this is something that keeps me up at night as the mother of a young girl who currently has misophonia. And I'll just say that it is really unfortunate. I'll just acknowledge that as a field, we don't have a lot of evidence from our science yet regarding which treatment is best for children. There's just a lot more work to be done. And I asked my own daughter about this. I think Jane earlier said, you wish someone would have just asked you what you needed. And I happen to have asked my daughter that, who's 11 now. Yesterday, I said, I'm going to get to talk to a lot of people tomorrow who are really thinking hard about this. And I said, what would you want them to do? And she just said, please fix it. And I think, that could be a call to all of us because we really do need to do work in this area to be able to determine how we can best support these children.
Yeah, I'll just add on to that. I do think this is my opinion. I do think it's helpful to see an audiologist to assess what the hearing status is. But I think it should be an audiologist who specializes in sound tolerance or tinnitus because they can generalize a little bit to misophonia and they need to be doing extra measures that are not typically included in an audiologic assessment because it's highly likely that she has normal hearing. And so they're going to need to do extra tests that can further assess her processing capability. So I'm happy to talk with you later about what those look like.
I'm going to add something too as well to help answer the question. Just to add on to what Andrew said, agree with all of it. But also, in addition, a couple of things to consider. One is that there's, as we all know, there are very, very few people, clinicians who, in any field really, who would claim to be an expert in this topic. So and sometimes those who do claim to be an expert, we might also question. So there's very few true experts, if there are any experts, is the takeaway there. So it's a bit of a challenge, right? We live in a world where we think about things from a very medical model, where if there's a disease, we look for the expert in that disease, right? That's the sort of the world we're all in. I would encourage you, and I would encourage your daughter, and I would encourage others, and we at our center do this encouragement very, very regularly, to also think a bit differently in the approach to the clinician, in the reach out, in the approach. You might try, might call this a hack. Tell me if it doesn't work, it's not a hack, but if it works, maybe it's a hack for you. And the idea is just describe without using the word misophonia. Describe what's actually happening. So the telephone call or the email does not have to say, I have a daughter or granddaughter or whomever with misophonia. Can you help? It does not have to be that. It can be, I have a daughter or a granddaughter or a whomever, and they're having really big, difficult emotional responses to everyday kinds of cues, everyday kinds of things in their environment. It's causing a lot of problems in our family, at school, at home. We're looking for ways to help regulate those emotions, like anger, and we're looking for like tried and true, reasonably evidence-based approaches. Can you help? Now, the trick is that's a mouthful. But I think that mouthful might actually be a bit higher of a probability of success for a lot of people, because the truth is there's a lot of people like who Andrew described, but they wouldn't call themselves misophonia experts. So now you want to get in the door, right? The first thing is you got to get a response, and you got to get in the door, and that we all know is really, really hard. And by the way, that's really hard everywhere. That is not just hard where you live or where your family member lives. It's very hard to get a response from a clinician. Very often, very hard to get a response when you reach out to them, because the pain point of the average mental health provider, for example, is not that we need more patients. Like the day-to-day experience, you guys who are clinicians know the day-to-day experience is we painfully have to turn people away every single day all over the place. And it's so getting through that first door, I think, is a really important step. And if you rely only on the expert with misophonia, you're just unintentionally setting yourself up, I think, for a lower probability of success. Also, shout out to Grace, who's here, maybe still, there she is, Grace. Grace and I meet with parents across the US and actually everywhere in the world when they reach out. It's mostly the US, but we meet with parents and family members and sufferers to help them think through, wherever they live, to help them think through strategies for navigating this question. So anybody is welcome to reach out to us at our website if you would like some help navigating these issues.
I would just to add on to that, there is the risk though, if you don't mention misophonia, that you'll end up with exposure therapy or something, because if it's considered OCD, then exposure therapy is that. So you can't necessarily, you can't just you still need to educate them.
All right. Well, this really presented a wealth of information. So thank you so much to our panelists. Thank you to our moderator.